we've had a lot of webinars going on, and yesterday, in fact, we had the All India Ophthalmic Society giving a very elaborate guideline, which has been drafted beautifully down to the minute details as well. The purpose, what we are doing in this seminar is, after the yesterday's AIOS guideline which were published, we try to talk to our friends and colleagues in the ophthalmic fraternity, and we try to ask them, do you have any clarification, or do you want anything which is not covered within these guidelines which would need clarification. So we have taken questions from several of our colleagues, and then we are putting up these questions here. This will flow in the form of discussions, frequently asked questions. So it will be largely a question answer session and not a didactic lecture. In addition to this, we have three other areas of focus. One of the areas of focus is on the mask. So right now in the PPE that we have been using, or we are supposed to use in future as well for the next few months or maybe years, the masks will have been most important and will continue to be the most important part of our PPE kit. This is, therefore, we thought it appropriate that we should focus quite a good amount of time clarifying, because a lot of our colleagues had quite a few questions and doubts regarding the different kind of mask, which is appropriate one and an inappropriate one, and which can be used. The second area of concentration or the thrust we will be giving is on the PPE itself, that is the coveralls. So the coveralls, as you know, have been from, as our Prime Minister said, which has gone from 0 to 2 lakh per day. Though the situation is that we have now been flooded with PPEs, there are very few people who are doing the right. That is the first point. And the second thing is, lot of us are confused about what is the right PPE that needs to be used in specific settings. So I would be using this webinar, me and Dr. Raju would be using this webinar to try to see if we could clarify the doubts of quite a few of our colleagues about the appropriateness of the PPE and the relevance of it. The third area of thirst would be, one is the air conditioning system of the hospital, the OPD and the operation theatre, both put together. What should be the appropriate air conditioning? Of course, the AIOS guidelines have put it very clearly, unambiguously about like what should be the right thing. But today we are fortunate enough to have an expert among us who is the regional director of ISHRAE, who is an expert in air conditioning systems. Together with our own faculty from AIOS and KOS, we will be having his opinion on what is the appropriate way in which the air conditioning should be handled, with some valuable inputs from him. We also have another expert who is Dr. Vinod, who is PhD. He is a biosafety officer dealing with safety in critical areas. He happens to be the biosafety chief of Biocon. Syngene is the clinical arm of Biocon laboratories, and then he happens to be one of the very, very few biosafety officers in the country. He is also joined with us. He has also joined with us today, and we are fortunate to have him. He will be discussing with us about the safety aspect and the sterilization aspects as compared as the virus lability is concerned. Let us straight away get to the meeting now. To start with, in our own faculty, we have two of our luminaries. It is a great pleasure to welcome Professor Mahipal Sachdeva for the meeting, and we are indeed honored that he's consented to be a part of this webinar here. He's the, as you all know, he obviously needs no introduction, being the chairman and managing medical director of Center for Sight, New Delhi, and he's been awarded the Padma Shri by the President of India. All of us are aware about it. He's our current president of All India Ophthalmic Society. We are also very fortunate to have among with us Dr. Y.L. Rajshekhar, who is president of our own Karnataka Ophthalmic Society here. He's together with the expertise of Dr. Y.L. Rajshekhar is the director of Shekhar Eye Hospital at Bangalore. With the help of Dr. Mahipal and Professor Mahipal and Dr. Y.L. Rajshekhar, who will be guiding us through this webinar. We also have the expertise of two of our colleagues and friends who are joining us from across the border of our nation, one from either side of our nation rather. We have a guest from ophthalmology friend from United Kingdom, Dr. Aravind Reddy, who is a consultant ophthalmologist for NHS and also has his private practice and is practicing at Aberdeen in United Kingdom in Scotland. He's also been the examiner for FRCS. In fact, he's as recently as a month back, he's been the FRCS examiner and had come to Narayan Netralaya. He's been handling PG education and training and was the program director for north of Scotland, and he's the regional advisor to the Royal College of Ophthalmologists. He's the lead clinician for Eye Health Network. And in addition, we have Dr. Manotosh Ray, who is joining us from the other side of the world now. He's based at Singapore. He's a senior consultant, Division of Cornea and Refractive Services, Department for Ophthalmology, National University Health System, Singapore. He's also the assistant professor and UG education director of Yong Lu Lin School of Medicine, National University of Singapore. All of you, Professor Mahipal, Sachdeva, Dr. Y.L. Rajshekhar, Dr. Manotosh and Dr. Aravind, Dr. Vinod and Mr. Madhukar, we welcome you all to the webinar, as also we welcome all the participants who have logged in. Can we start with a short address by Professor Mahipal Sachdeva and then Dr. Y.L. Rajshekhar, please, and then we'll go to the clinical part of it. Thank you.
Thank you very much for having me over to this webinar. I think all of us are passing through a situation which none of us ever thought or even imagined or dreamt of that such a thing could happen in our lifetimes. And the situation is so very fluid that it's evolving by the day. And as things stand today, India had a lockdown. I think today is the 50th day of the lockdown, and there are going to be some relaxations from Monday, Tuesday. As it is, things are getting a little bit relaxed because there had been a very significant impact on the economy of India. And today, as we talk, there is an economic stimulus that is being announced by the finance minister. So the coronavirus is still something that is impacting the entire globe. Over 4.3 million cases have been there. There are a lot of deaths that have happened, and India today is the 12th nation as regards the numbers. It was way down, but as time has passed, India is also showing an increase in the number of cases, and we are close to the 75,000 mark as of yesterday. And what is important is that till date, there is no cure for this particular disease, nor is there any vaccine which is going to be available over the next couple of months. So the issue therefore is that there should be safety. We should try to blunt the curve as to the speed at which the number of patients are being increased, and also now there is a focus back on livelihood also. So I think it's a very trying time, and none of us are actually have ever experienced. So there is no expertise that is available to any one of us to say that this is the right path or this is the wrong path. There are countries like Sweden which have looked at herd immunity, and there are countries where we are talking about a complete lockdown and a second phase coming and a third phase coming. So things have to be changing or evolving on a, I would say, regular basis, and the basis that we have to adapt ourselves to the changing environment that is there. Now, what is going to be very important for us to understand is that corona will be there. hopefully all of us will be there, and ophthalmology will be there. So that is something which is very important, that how do we coexist in the COVID era, as to how we are going to adapt ourselves, how we are trying to make it safer for the healthcare providers as also for the patients, so that nursing homes don't become a hotspot. Actually, in US today, meat places where meat processing is there, nursing homes, etc., and old homes. These have become actually the hotspots for the COVID epidemic. So what is very, very important is that we need to follow certain guidelines. Obviously, it will not give you 100% safety and efficacy, but the best that the minds were able to do, AIOS consulted more than 200 people. I think all of them came forward very, very in a very positive manner, and we had about 12 subsections that we had for the various subspecialties, and we have been able to put together a document which is more than 100 pages, or it's about actually 101 pages, that was circulated to all of you. Dr. Rajshekhar was actively involved in part of the document framing of it, but I think everyone came forward, whatever was the expertise that was available. So it's more of an expert document that is there. We would be issuing corrigendum. There is one thing that was pointed out to us regarding the concentration of hypochlorite solution. So that's the only thing that has come to our knowledge. But in case, even in this discussion, if we come out with certain things which needs to be altered or changed, it is obviously open for all of us to change. And we look forward to a continuing dialogue and discussion. And as we have two experts from outside of ophthalmology and two experts from within ophthalmology who are at different phases of the disease in England, as you all know, the number of patients and the number of mortality is pretty high. Singapore also is having a lockdown, which I think has been relaxed to some extent today or yesterday. So we'll try to bring whatever knowledge we have on the table and move forward with the common thread that hope all of us stay safe, healthy, and also the ophthalmology practice, we come back to the practice in a safe manner. So I think these are my introductory thoughts, and we can go ahead with the webinar. Thank you.
Can I request Dr. Y.L. Rajshekhar to just...
Thank you, sir, Dr. Sirish and Dr. Raju. As our President, Dr. has rightly put it, this is a fluid situation, this is a new situation, it's a dynamic situation. Each of us are learning and going through this phase. And as the lockdown is going to get released and more ophthal patients start coming into our clinics, it's in everybody's mind as to how we should start, what is the right thing to do, what is the right kind of PPE, right kind of environment that we need to have, and what are the risks to us and what are the risks to our patients. These are all the various questions that are coming up. And when we try to look for these answers, the answers are coming from fields like the PPE and ACs, the ultraviolet rays, the virology. See, each one, if you look at, I was surprised to know that the study of masks itself is a course by itself, about 1 to 1.5 years of diploma on called maskology. And there is a study of ultraviolet rays itself, and now biosafety things itself is a specialty by itself. So it's obviously impossible to know everything, but at least to know what is relevant to our specialty, because basically we are all scientists. When we go to our patients, we go to them as scientists, and they come to us with a lot of trust in us, thinking that we would have gone through all the good and bad of it, and we would have come up with some kind of what is right for the situation. So, and hence, I must congratulate both Dr. Sirish and Dr. Raju for putting up this kind of webinar. And we are at ophthalmology front, when too many opinions come, then what I practice in my clinic, what is the right thing, whether I should listen to friend A, friend B, or look up into books myself and come to a decision, because this is not what I have studied in my during the course of my education. So it's a new thing. So when we were in such kind of a dilemma as to what is right that is to be followed in the hospitals, then Dr. Mahipal Singh Sachdeva under AOS, he brought in all experts. In fact, in his expert team, a lot of specialities from across the country, including various fields like both government sector, private sector, institutional, private medical colleges, research places, and even international experts. And sometimes when subjects were beyond ophthalmology, like if it involved microbiology or involved virology or even air conditioning and all that, experts from various fields were put in, and then giving them a fora of how we practice, and in COVID era how we should practice. That's the time AAOS has come up with such a wonderful document. In fact, it's extremely good. To me, if I follow AAOS guidelines, I'm doing justice to my patient. Anything beyond that I do, it's a value addition. And as Dr. Mahipal Singh Sachdeva said, whatever guidelines are there, he's open to improvising in the due time with the more knowledge that's coming in. I also request viewers to have that guideline and extend the knowledge over and above that, but not to go beyond those, not to take anything else as a replacement to that, because then, as a medical fraternity, we'll be again flooded with too much knowledge. And finally, we'll have to do something. So when you have to do something, it's better to listen to, have one set and go on improvising on that. And in this, I'm sure we are all going to learn a lot. And more value addition is from places where people have been practicing. We would like to know what Manotosh is doing, what Aravind is doing, what kind of patients they see, how is their OPDs. And also we would like to know what is the kind of patient flow. Because here, I don't know whether it's Indian mindset, we are only having around 15 to 20% or 30% of patients who are coming in. How is it in Manotosh's place? How is it in Arvind's place? We would like to know that. I think this is a wonderful webinar. We are all going to enjoy this. Over to Dr. Sirish and Dr. Raju.
Yeah, thank you very much, sir. Point very well taken. AOS guidelines is the mother of all guidelines, and we have to follow them religiously. But we'll try to understand scientific concepts when we are using these. Like suppose I say N95, what exactly it means. So what are the limitations of having our surgical mask and how to improvise. So these are the small things over a period of research. As you said, maskology, we have been doing this research over the last 1.5 months, and some points which we thought we can share with our colleagues is what we are trying to help our colleagues with. Yeah. Dr. Sirish will now start telling us regarding the various types of masks. To begin with, the surgical mask and its limitations, and then we'll tell you about the various types of masks, and including half-piece respirators and the full-piece respirators with a demonstration.
We thought of including this because there were a lot of queries regarding it, unimaginably high. And not only that, the market is flooded with mask, N95 mask. Any mask worth its name, they just name it N95. And there are so many sub-varieties in the N95, and this is leading to so much of confusion. And the moment we started research into this, you won't believe the number of queries which we had to handle every day and then try to identify. Everybody would send me a photo of N95. Is this an original N95 or a duplicate one? So flooded with requests like a mask. So a lot of things have been collated and then collected. Obviously, all of you know that there is this surgical mask which we commonly use in our operation theatre. This is called as the 3-ply mask. It is called as 3-ply mask because it has 3 layers within it. If you cut the mask here, it will have 3 layers in between. So there is one central layer which is surrounded by 2 layers on either side of it. So the central layer is called as the melt-blown layer. Melt-blown layer or the central layer is the most important layer which does the filtration in the mask. So apart from this, the outer layer and the inner layer are more or less fabric, but then they have certain special qualities. The fabric on the outer part has a speciality where it is designed to repel water. So if the fluid falls down, it has a speciality whereby it repels water. Whereas on the inner part of the same mask, it has a speciality whereby a little bit of moisture which comes in tends to get held here and does not flow down. So this is the speciality of the 3-ply mask. This comes with 2 varieties. Of course, as you know, one comes with something where you tie it at the back of your head and another one with a loop behind your ears. The one with the loop behind our ears are not appropriate for our use, not so much in the surgical setup, because when we put this with a tire here, it fits the face far more snugly, and then we can customize it exactly according to the shape that we want and the size of the head that we have as per our need. Whereas one with a loop is with a fixed design, you don't have too much room to manipulate that mask, and it may be more appropriate for non-doctors or in non-critical settings. So this is about the 3-ply mask. Coming to the N95 mask, I wouldn't be discussing about the masks other than the N. So there are 3 kinds of masks here. One is called N mask, P mask, and R masks. So based on the oil resistance, they are divided accordingly. So the N mask, or the one which starts with N, usually is impermeable. It is not oil resistance. So N stands for not non-oil resistance. Of 0.3 microns are filtered by the mask. This is called as N95 mask. We have 2 other masks in addition to this. The other is called N99. N99 mask is the one which filters about 99% of the particulate matter. So that is how it is designated as N99 mask. So we have a subset of these masks also. So they are called FFP. FFP is full face respirator. So FFP basically, it is a designation which has been used by the European Union for determination of the N masks. So FFP1 has a filtration of approximately about 85-86%, whereas a FFP2 has more than around 92 to 94% of filtration. FFP3 has the highest filtration of about 99%. So the maximum filtration. If you see this mask, this has a dome-shaped curve to it. This is one variety of N95. This is a non-collapsible one, whereas this mask, which is a folding N95 mask, which is which can be folded in this way. This is a N95 which is compressed. It is preferable to choose a N95 mask which is shaped like this. Why so? The reason is, the advantage of these masks is they cover most of the face, point number 1. The second is they are made according to contour of the face. So you have your chin going in, then when you put like that, You have the chin, which is the chin part of the chin, the nose most importantly, and the whole of the mouth, and then it comes all the way till the lower part of your jaw. So a good part of your face gets covered, and then it follows almost the contour of the face. It is given a V-shaped V shape here, so that it follows the contour of the nose here, and then this does not collapse easily. It holds itself like a dome. So this is rigid. In addition to this, this comes with a nose clip here. The nose clip is extremely important in a N95 mask because it is, let me correlate this with a helmet of a scooter. So you have helmet of a scooter which is very, very protective, but when you put the helmet and no strap, it is of absolutely no help at all. So the helmet can just fall off and then you might meet with a ghastly accident, and it was no help putting the helmet. Even an N95 mask, if it is not snugly fitting the face and then holding to all the areas of the face, is almost absolutely useless. Therefore, the nose clip becomes extremely important, that when you place the mask over here and you press the nose clip along here, then it does not leave any room for the air to come out of this area. So you should have almost like an airtight area. So when the lower part of it covers the whole area and then the upper part is covered by the nose clip, you have a complete snugly fitting mask here. Then the next point comes in this valve which you are seeing here. Now, if you see this N95 mask, there is no valve here, whereas this mask has N95. You can have rigid masks also without the valve. This is called as the expiration valve. Now, when you have an expiration valve here, it makes your breathing far more comfortable. Suppose you have a rigid mask like this, but no expiration valve, then the whole thing is covering your face, and then the carbon dioxide gets accumulated within, and then you don't have a proper way in which you can breathe. So the breathing becomes more uncomfortable. The expiration valve makes your breathing far, far more easy. You are more comfortable breathing because you keep getting, you can push out the air and then it becomes comfortable. Now there is one small disadvantage of it. Now with the valve, this is a one-sided valve. That means when you blow inside, the valve opens up and lets the air come out through this area. However, since it's a one-sided valve, it won't let anything from outside get in. So this means that the person who is putting this mask is very, very well protected because there is no air coming from the outside to the inside. But you need to remember that since your air is going outside, and say, for example, if we are having, we are affected by the virus and our droplets can easily move out of it, and then we have a small chance of transmitting this infection to the person who is staying in front of us. So even in these valves, there are two varieties. One is one which has a valve right in the front, another which has valves on the sides here. So in comparison to these two masks, the one which has the valves to the side is a bit more safer because whatever we exhale goes to the side, whereas whatever we exhale in this comes directly outside. But then again, one very, very critical thing about it, since this exhalation valve lets the air come out. So because of this, what happens is, this is a mask which we cannot use in any area which is highly sterile. Say for example, in an operation theater, you cannot use a N95 mask which has an exhalation valve. You can use this in settings like outpatient department, where you have a good, even a good protective shield on your slit lamp which is blocking you, or you are still able to maintain a social distancing between yourself and the patient. Then when you expire, the droplet may not go very, very far. It may just come near and then fall down. So you can protect your patient from having, getting the infection from you as well. So you are protected, but then you need to protect the patient also from being equally protected. So coming to the other type of N95s that we have, as I said, all of them serve the same purpose as far as filtration is concerned. When the thickness is concerned, the filtration is measured, only then it is approved. So any N95 mask means that it has a certain degree of filtration. But then even in this, there will be subcategories. Like say for example, if the central material here, which again can be a melt-blown material, is again a carbonized material, then it is more for an anti-pollution mask than for a surgical mask. So you need to identify that. You need to go a bit deeper into the type of N95 mask that you are procuring. Look into the material that goes into it, whether it is a surgical mask or a non-surgical mask. In fact, some of the companies, if you go to the website, they will have when you put in the number of the mask there, they will give you details of whether it is a surgical mask or a non-surgical mask. So going into more further details about the material here and how to identify based on the material is outside the purview of your webinar, but it might suffice for me to say that please remember, even in N95, there could be surgical and non-surgical. Please identify and differentiate these two based on the the website information that you can get, and then you could do that. So if the N is preceded by K, so if you have something like KN95, it is the same N95 mask which is made in China. So you can, the masks made in South Korea have a different designation. The masks made in Europe have a similarly different designation, which will be very minor changes in the denomination or the alphabetical specification that are given in the mask. Now, one more interesting thing that comes. So that is the color of these holders which you have. When you have a yellow strap and a white strap, these mean that these are N95 masks which have a high degree of filtration or an adequate degree of filtration. When it comes to blue one, it is of one lower quality. When you have a red marking like that, I don't have a one with a red band here. That is N99 mask. That has the highest amount of filtration. So if you see a band with a red here, that means that is the best quality mask or the highest filtration that you can get. You can also do with yellow bands as well as white bands as well. These are acceptable masks in your surgical practice. Can I share the slide here, please? Yeah. So now we will come to the discussion part of the mask here. If I can start, of course, we had yesterday we had a discussion through the All India Ophthalmic Society guidelines where we were talking the most critical thing or the important thing that is being discussed now all across the world, not just in India. So reuse of N95 mask. Initially, Indians were known for Jugaad, but then the Jugaad is catching on now all across the world just because there is a huge shortage of the PP and N95 mask. So we had a discussion about the reuse of the mask. Can we have Mahipal sir to talk about how, the reuse of the N95 mask, how we can do it?
So actually, when you are looking at the reuse of the N95, this is the thing that came in from All India Institute of Medical Sciences, where they said that there should be 4 units of N95 that should be given to healthcare workers. And you should keep it in a bag and then take it home and expose it for, aerate it and expose it for 72 hours. So every 4th one you can use it, and you can use it 5 times maximum. That's what the AIMS guidelines have been, and that is what has been recommended, that 72 hours of aeration under good temperature, and keep it open, and then you can reuse it on the 5th day. So you have 1, 2, 3, 4, and 5th day you can reuse it, and you reuse it for a maximum of 5 times.
Can we have this slide, please? It's on slide share. Yeah, since okay, I'll just put in one of the studies which happened, which has been one of the first studies which happened on the reuse of mask has been from the journal Lancet, where it was published right in the beginning of March. So I'm going to show the findings of that. Is this a screen share?
Yeah, it's sharing.
It's sharing. Okay, if you can see this, this is the finding that they had. So this is the mask inner layer. Sorry about that. This is the number of viruses at the time period of the inner layer of the mask, and this is the outer layer of the same N95 mask. We can see that almost till about, this is an acceptable level of virulence which is there on the mask. So when we reach this, the bacterial count, the viral count would have reached to less than 99.99%. So this is almost about like 160 to 170 hours, which works out to roughly about 5 to between 6 days. I think the AIOS guideline is pretty similar what we have come up with, very, very close. So to be on the Mahipal sir, could we say, about 4 to 5 days, or was there a criteria which was used when the 4 days were put? Is one of the questions I would want to.
We did not use any criteria ourselves, but the criteria that was used was what AIIMS had said, and I think they have kept it down by about. So normal typical hours would be not more than 9-10 hours, this thing. So ideally we should not use it for more than 6 to 8 hours at a given stretch. 6 hours is what is being said. So if you are looking at that and you are putting it 5 times, that would be only 30-40 hours or something around that, which would not be too great. And then the second thing that you have to understand is that this is talking about viral load. We are talking about non-COVID eye hospitals. So there's a big difference between COVID hospitals and non-COVID hospitals. So that also needs to be looked at, though obviously we'll have asymptomatic patients who would be coming. That's the only problem. But otherwise, we are not supposed to be dealing with COVID patients, screening, history, etc., fever, whatever if they have, so then they should be referred out. They should not be allowed to enter the facility. So I think that is the basic thing. 5 is still, I think, within a very, very acceptable limit, using it for 5 years.
Yeah. Sir, one of the other questions that was asked in relation to mask was, there is quite a few information, or rather WhatsApp messages which have been going around, where they say that if you put a 3-ply mask on the surface of an N95 mask, you can actually prolong the number of days that you can use the N95 mask. This question specifically is coming in because of 2 reasons. One is there has been a bit of a shortage of N95 mask. Now, of course, the availability is improving over a period of time. Hopefully, in about a month or 2, it should become much better. But some shortage has been there. And the second reason has been a mask which is costing about 30 rupees is being sold for 250 to 300 rupees. So till the prices come down, is this something we can consider?
Okay, so the first thing is that there is one thing talking about PPE and wearing those things. The second thing is the discomfort that a patient or the doctor actually has when you do. So if you have a N95 and you're putting a mask on top of it, I think it severely restricts the amount of oxygen that you are getting. There have been reports of even while driving, if people have been wearing, so being having air hunger at that particular time. So I think the other thing that you have to also remember is that dentist, ENT and ophthalmology comes in the tier 3 level of people who are coming in close contact, and there is a physical barrier shield that has been recommended. So once you have a barrier shield, the second you have an N95, and third you want to put a 3-ply, I think that's going for an overkill. And the main issue is that we are not dealing with COVID patients, obviously asymptomatic, as I said. And the third thing is that the mask actually is more important for the patient rather than the doctor. So it's the patients throwing out the fomite or also the exhalation that is more important. So the type of quality of the mask that a patient is wearing is going to be important. I think it may be a better idea that 3-ply mask, even if we have to give them free of cost, because there's a price control. So you are still getting these 3-ply masks at about 15 rupees or whatever it is. If we give that to the patient, that would be more visible rather than having wet cloth masks which the patients are wearing. So I personally don't think that there is a 3-ply which is required on top of an N95. If you can, you don't have any breathing problems and all, you can do that. But I think the front visor is something which is very important, and now at least in Delhi we can get it for about 60, 65, 70 rupees plus GST. So that studs came out earlier, that was about 200 plus, but now a lot of other people have been manufacturing. So I think all these things put together would be something very, very important that we could have. But obviously, if somebody wants to go in for an N95 plus a 3-ply on top of it, I have no issues on that. putting the N95 on the ears at times is slightly uncomfortable, and if you have to wear it through the day, it's uncomfortable. So there are a couple of WhatsApp on where the glasses you can put a button or a bead or something and do that. For me, it's going to be very, very difficult on top of a turban. So I really don't know if you have any specific journal reference that it's better to put a 3-ply on top of an N95. I would be happy to listen to that.
The whatever publication we have, they do have material on that where they say that the things that 3-ply would help is splash, because there are specific criteria where we would be rejecting the N95. So I'll come to those 4-5 points there. I have it on my slide share.
Okay.
Can I? Yeah. Before till I put the slide share, Dr. Vinod, we do have criteria which is actually very simple, and this is as per the also according to some of the international guidelines also which have come in. What are the alternate ways of sterilizing a mask which we can practically do in addition to keeping it for a few days and then coming back and reusing it? Is there a rapid method or a shorter method which doesn't destroy the mask so much?
Yes, Dr. Sirish, thank you. There are some evidences are being surfacing that there's some type of N95 does undergo the autoclaving cycle, and I think that is the very simplest physical sterilization that we have everywhere. And they say that some of the masks can withstand that high temperature of 121 centigrade and 15 psi pressure for post 3 cycles. There are some evidences there where they do the cycling and followed by drying to make sure all the viral loads that whatever we were discussing a few minutes back are taken care. But in biosafety purviews, what we suggest, especially when they go for on-site and do stuff, we recommend along with the 3-ply mask also a face shield, because one of the key carrier of the virus is the droplet nuclei and everything. And as I know Professor Mahipal was mentioning that most of the mask wearer is the important criteria here, since the patient is wearing the mask, and we can avoid most of the movement of those droplets and exposing the doctor or who the medical practitioner who is addressing the patient. So at a very close proximity, especially in some places, we have suggested that to wear a 3-ply mask and a simple face shield, so that in case of any droplets or splash coming up, it protects them, and same time they can carry on with the surgical mask.
So there are 2 face shields. Actually, there is a barrier sheet that we are recommending between the slit lamp and the between the patient and the observer. So that in itself is one. You should be talking the least, and what you are talking is the plastic visor or face shield. That's exactly what we are talking about. So I think that should offer great this thing. And in case there is an acute shortage of N95, as he said, autoclaving. But I think plasma sterilization is something which will not cause any damage to any significant, because the temperature doesn't go to 120 there, and I think that should be able to take care of it.
I agree with you, sir. The plasma sterilization is also available. There are other sources also there, but since in our the most frequent, I would say, abundantly easily available is autoclave. But I agree with you. There are some cold sterilization processes available wherein it gives very limited effects for the integrity of the mask, so that it can extend for a longer period of life.
This question is for Dr. Manotosh and Dr. Aravind. So, are you people reusing the N95 there, or do you have any protocol as such that you want to share with us?
Yes. Hi, Raju. Sorry. I have a different take on the N95 mask, basically. So, first of all, let me tell you that in Singapore, we don't...
I think you need to come a bit closer, sorry.
Can you hear now?
Yeah, much better.
Okay. So, first of all, let me tell you that we don't reuse N95 mask in Singapore, never. Secondly, the N95 mask, I'm not sure about India, but in Singapore, it comes in 3 sizes. It comes small, medium, and large. So you have to understand that every face is different, every face size, everything is different. And one mask, you cannot just go to a market and buy one N95 mask and fit on your face. So you have to go for a fitting. You have to go for N95 fitting. In Singapore, whether it is COVID or no COVID, we go for yearly mask fitting, and the fitting is done by a trainer, which is basically expert in that area. So what they basically do in Singapore, I mean, we all have to go through it. Basically, they subject us inside a hood, and then they fit different kind of mask. And through a hole in the hood, they inject some bitter aerosols, all right? There's a kind of spray, which is a bitter test. And if you test that spray, meaning that your mask fitting is not good, so then you try the second size, and eventually you try all the sizes, and which size is basically regular N95 mask, because other masks will not fit on me. So this is how we do in Singapore. But I'm not sure in India whether there is 3 different sizes or not. And secondly, I have another take on the people are talking about, that surgical mask, and then you are putting N95 mask on the top of it. You are basically, to my opinion, you are basically losing the activity of your or effectiveness of your N95 mask, because everything is percolating through your surgical mask there. So I don't think that is necessary at all.
So how is the use of 3-ply mask versus N95? Do you differentiate between them, or?
Well, we have a criteria here. I mean, I'm not sure whether they'll be asking me later on. So basically, in an ophthalmic setup, we are all using the surgical mask. But we have a patient differentiation. I mean, basically, it comes from the triage. They tell us whether it is a low risk, no risk, or intermediate risk. The patient with no risk, we just see with the surgical mask. Patient with the intermediate risk, we use the N95 mask in an isolation room. And patient with high, they don't come to us. They straight away go to the we are a COVID hospital. Basically, we have treated almost 1,000 patients. And till now, we have 200 patients just 100 meters from my clinic. So basically, those patients, they don't come to us. And we rely those people who are doing the triaging. And we have an isolation room. And if there is a mild symptoms, we don't take any risk. The patients are designated to see those particular patients. They go to the isolation room straight away. They don't come to the public area. And we don all the PPEs, including the N95 mask, and then we see the patients there in the signal.
What is intermediate risk?
Intermediate risk is the patient has mild risk, having mild cough, but not really respiratory symptoms. Those are the mild risk. So what the triage people do, they call the doctor from the triage, and they tell us, this patient has mild symptoms, you want to see. Then I quickly go through the medical history, because we have the electronic records. And I see that if this patient is really need to be seen, it is urgent. If I see it is not urgent, I say you reschedule this patient. But if I see this patient has to be seen immediately, the patient will come to the clinic, but it will go to the isolation room.
So I think that supports what I was saying, because we are taking the triaging and the history outside and checking the fever, and we are not basically, as per what our guidelines are, that you need not, you could send them to a COVID designated hospital or a multi-specialty hospital. So in case we are getting all these negative patients, then I think the 3-ply mask with a plastic shield would be more than adequate. You can wear a N95, that's for sure. So wherever we have written it's N95 / 3-ply, but N95 is pretty good. I think putting another 3-ply on top of it may not be that required.
I absolutely agree with you, sir.
Yeah, Dr. Aravind?
A quick comment from Dr. Aravind, please.
Yeah, thank you, Ashutosh. I think Manotosh, you covered most of the stuff. And in UK, it's very similar to Singapore, but there is a lot of emphasis on a single use. The only time you're allowed to use a mask for longer than one patient is on a sessional, when you're doing a clinic or face-to-face consultations. So you can use it for a sessional basis, and that is the time where the patients who are not COVID suspects or are seen. So other than that, it's usually a single-use situation all the time. Surgical masks are always used when there's no suspicion of COVID. So we don't use the expensive FFP3 or other masks when there's no suspicion of COVID.
And do you use these half-piece respirators, which are
Like
reusable ones, like this?
You have these half-piece respirators. Of course, we wouldn't need these full-face respirators here like this. They are like too superfluous. But a lot of our colleagues are asking whether, the way they're calculating is this would cost about like 1,500 to 2,000 rupees in India. So then the respirator here or the cartridge needs to be replaced only once in about roughly 20 days to 30 days. So would this actually work out more cost effective is what some of our colleagues are wondering. Would anybody want to comment on that?
We don't use in Singapore. I'm not sure about it.
So in the UK, the masks, those kind of masks are used only when aerosol generating procedures are performed on COVID patients, proven COVID patients. So the use is very, very minimal of use, in the UK at least.
Dr. Sampangi, I just want to add, I think somebody was mentioning, I think Dr. Manotosh was mentioning about the fit testing. I think once you escalate yourself to a higher degree of respirators, the bearer should undergo the fit testing to make sure that the bearer can really work with the mask. And it's not about the the higher level of respirator, but also the fitness of the bearer has to be accounted for, as well as like Aravind was mentioning, it is also dependent upon the process and activity that is involved. If there's a lot of aerosol process, or if there is a biocontainment requirement for that kind of an area, yes, definitely you should go based on the higher degree of respirators and personal protection. I just wanted to share my thoughts.
Okay.
Just one more brief one. Face fit testing is really important because there are different types of masks and each of our faces are very different. And I've been through 3 different tests because a couple of them didn't fit very well. The testing is so extensive that there is absolutely no contamination coming out from yourself, from the respiratory secretions. So it's compulsory that all of us have to be face fitted. Some of them are happy with just a simple, the face fits a simple, straightforward N95. But I've been tested, and this is the only thing that fits me. It's again an FFP3 mask, and it's manufactured by 3M, and 8833 is the mask that fits me perfectly. Absolutely no air at all comes out when I wear this mask. But having said that, if I wear this for 4 hours, I'm really, like Professor Sachdeva was saying, it's really difficult to work for long periods of time with this mask on. So it's only for aerosol generating procedures that I use this.
Arvind, what you just mentioned, the size of that mask. So we need to submit to the hospital authority every year that this is the size of my mask, and they keep it note in their record.
Okay, point well taken. As of now in India, we don't have wide availability of the different sizes of masks. This is actually one fixed size of mask that's available, and as of now we don't have it. But probably over a period of time, I think we should be having different size masks which could be made available, and then we could become more specific. So we'll move on. Another point.
Yeah, just a point. If it is not fitting now because we don't have the availability of different sizes of masks, at least what we can do is to tape it around so that the leakage is reduced. That's what I can say.
But I think we have different sizes, though there is no specific fitting that's done in India. But I think you have small, medium, large availability from 3M.
Okay, sir.
Yeah.
The next point which we've had our friends asking is regarding the entry point screening specifically. The guideline that's been given by AIOS is that we could use linen gowns for the entry point screening. So again, this is one inquiry which has been happening actually since quite a few days, whether we could use the same linen gown and then we can take it. And the second, there's a question which is attached to this is, we do have very easy access to disposable gowns also in a lot of our operation theaters. The question is, can we either use this interchangeably, and also whether linen gowns which catch more of the droplets is the question. Mahipal sir?
So actually, we have not categorically defined between a linen and a disposable one. In the disposable one, there is I think 90 GSM or something. There is a specification as regards the cloth, the thickness of the disposable material that is used. So you could use either of the two. So it's basically, I think the disposable one is reasonably inexpensive. You can get it for about 150 rupees odd. The other thing is that if you are using a linen one, that also would serve a lot of purpose, because the donning doffing is important, and then you should ideally put it in a disinfectant, basically a hypochlorite solution or something like that. That's what you have to put it in once it is taken off. So I did see a movie from I think Jodh Mehta was showing the procedure at SNAC, etc. So there, within the hospital, people were not wearing anything, not even a linen mask or a linen gown or a disposable. So they were in their normal aprons, etc. But obviously, those aprons need to be discarded or not discarded. They need to be cleaned with soap water or with hypochlorite at the end of the day. So again, see, the point is that as Dr. Reddy was also talking, and Dr. Manotosh was also talking, there is a difference between when you are going to intermediate and high risk. So basically, we have issued guidelines for low risk institutions or eye care facilities. That is where we are looking at. So I have no issues in a person using a disposable gown or a linen gown, but that is the person who will come in contact with the maximum number of people who are walking in, taking the temperature, etc. So it is very, very important there. And the gloves need to be there, and then in between the alcohol sanitization or disinfection needs to be done, and it's better to have it done on the gloves than on your bare hands. And I think over time prices will come down. I distinctly remember we bought the 5-liter can for about 2,000 bucks, and now it's down to about 700-800 rupees for the alcohol-based 5-liter can. So I think as more manufacturing is coming in, the prices will come down and the availability is going to improve.
So I thank you, my person. And now we'll go on to the another most important part of it is the air handling in the OPD as well as the OT. And we have with us Mr. Madhukar A, who is the regional director for ISHRAE, and he is from the Bangalore chapter. Thank you very much, Mr. Madhukar, for joining us. And I'll ask him the questions and he'll be sharing his answers. And these questions were collected over a period of time, and these were asked by the members. And one problem that we have in ophthalmology is we have different sizes of our private practice. We have big institutes, we have tertiary care private institutions, and we also have small private practitioners. So, and each one of us have different kinds of operation theaters as well as facilities that are there. And we also do a lot of camp-based surgeries, wherein a lot of cost constraints are there. So using limited resources, we are doing these things. So what we have with us is the problem statement that we have is, I'll just share my screen. Wait. Yeah. So I'll ask Madhukar sir. So what we have, the problem that we have is, although the NABH standards say the AHU is required, the OT with split ACs are most commonly used across India. So the questions that there are, this is a question from Mr. Praveen Kumar, Dr. Praveen Kumar from Shivakasi. He says, in this COVID period, everything is confusing regarding starting the OT. We may use the PPE, which may prevent spillage or aerosol, but the patient will be there in your recovery room and he'll be breathing out. So whether if I have both OTs, whether it's a laminar flow OT and a OT with split air conditioner, which one would be the one that I should use?
The question here is, let me just talk about, I think this is the question what we are talking about?
Yes. If we have a question wherein the patient has, we have a laminar flow OT and a non-laminar flow OT. Okay. Which one should us choose with respect to the air quality part?
Okay, whether it is laminar flow OT or no laminar OT, the patient is going to breathe into the OT. See, now let me just explain to you first that what are these types of air changes and what is it that the laminar flow does or entail. See, basically laminar flow is a pattern.
1 second, I think maybe we should ask him to run his presentation because that will give us a little more insight before asking questions, no? Is that all right?
Yeah, he can give his presentations to start with.
Yeah. Okay, then I will go back to my slides which starts about the basic ventilation and air changes that are required, which are recommended. Okay, so then I will go back to a few of my slides. Okay, see basically there are 3 types of surgical classifications when it comes to operation theatres, and the one is the class A surgery, which is performed under topical, local or regional and with proper pre-operative sedation. Excluded are intravenous, spinal and your epidural procedures, which are class B or class C surgeries. The second category is the class B surgery, which provides the major surgical procedures that require the general or class regional block anesthesia or support of vital body functions. The class C is provide major procedures that require general or again regional anesthesia, which supports the vital body functions. Now, as per NABH, super specialty OT means operation theatres for neurosciences, orthopedics, cardiothoracic, and transplant surgery. But unfortunately, I have been looking all around, but there has no been classification specifically for ophthalmology. However, we may have to choose the operation theatre condition, which is quite closer to that. Then, what are these ventilation standards or the suggested indoor air quality standards as per ISHRAE? ISHRAE is an international body which talks about various aspects with respect to ventilation and indoor air quality. Now, there are certain areas where there needs to be positive pressure and there are some areas which needs to be under negative pressure when it comes to handling of the air. So, some operating theatres, say for example, need a temperature of about 20 to 24 degrees centigrade, maintain an R height of relative humidity of 30 to 60%, and with positive, and you may need to have about 20 air changes with 4 outside air changes. So these are some of the standards and guidelines which are available for a specific type of operation theatre which you would be doing. So ultimately we may have to look at some options wherein we fall closer to what is the kind of standards that we need to use. Now, coming back to the conditions which again recommended by NABH with respect to your positive pressure and negative pressure, the minimum positive pressure that is advised by ISHRAE is about 2.5 pascals, whereas NABH recommends about 4 air changes per hour and 20 air changes of recirculation air. And however, the temperature conditions as described previously remains between 21 to 24 degree centigrade, or if you want it in Fahrenheit, anywhere between 72 to 76. So with a relative humidity of 40 to 60%, class B and class C between 20 to 60%. Now, coming back to the question, basically what happens in a laminar flow operation theatre is that why do we need a laminar air flow is to sweep away whatever the disinfectants that could be the patient would be breathing or anybody would be breathing in the OT. So what happens here is when the air is coming in from your HEPA filter from the top, the flow pattern, generally the return air are provided at the bottom. So what is happening here is this creates a kind of an air curtain or a protection around you when you have a velocity of air coming in front of you. So this creates a barrier within wherever you are standing, and the airflow is from top to bottom, and generally you have the return air at the bottom here. Now this is the place where you have your generally where you have your return air. So in a laminar flow operation theater, you have the supply air coming from the top. Preferably you have either bigger area of HEPA filters, or maybe you will have one big HEPA filter in the center and two other areas adjacent to as per the OT design. So you bring in this air which is flowing from the top of your diffuser here, and the return air is taken at the bottom. So what is this effectively doing is, this is creating a sort of an air curtain within you and the operation theater table. I hope this explains, and probably we can, I would come back to you, Doctor, to take the next question. I hope it is clear.
So the take-home message is, if you have two OTs, then better operate in the OT with the laminar.
Laminar, obviously, definitely.
No question.
Yeah, because that is safer.
The next question is, see, most of us, even if you have a AHU now, because of the lockdown, you are not able to find the workers coming into service here AHU, and you are left to fend for yourself. Is there a way that you can increase your air changes or etc. Yourself, or you require the help of the engineers to do this for you?
Okay. See, a normal operation theater cannot be converted to a negative pressure operation theater without HVAC engineer visiting this site. See, it is just not possible that you have a fan or you're trying to do something else with whatever you want to have without a HVAC engineer visiting this site, because this involves a lot of detailing with respect to the design. Let me say, for example, I will give you an example which says that you have a split air conditioning system, and now you bring in an air change, or you want to bring in a fresh air from outside or outside air to create that air change. Now, what happens to the temperature within that room? There's an increase in the temperature within that room, because the outside air which you are getting will be an ambient air in a typical summer scenario like what we are now in April, May. In a temperature in Bangalore would be somewhere around 35 degrees, or if you take about Chennai or Hyderabad, it will be somewhere around 40-42 degrees. So you are trying to bring in an air which is at 42 degrees within your air conditioned area, and this drastically has a serious impact on the fluctuations in temperature within the operation theater. So the temperature which you are maintaining at 22 or 23 may shoot up to drastically to 27 and 28. With all the kind of personal protective equipment that you would be wearing, and with this kind of an increase in temperature, you would be sweating all over, which is not advisable. So it is definitely not feasible to try to do something on your own, other than getting into some sort of an expert advice. And also, yes, the installation of these type of fan filter units or your HEPA filter units, etc., are not going to involve too much of repair activity. However, once you visit this site, you will be able to analyze without disturbing too much of your day-to-day activity what can be done. Or in the simplest thing what we can do is, you can have something called as a treated fresh air or treated outdoor air. That is, your air which is coming in at 45 degrees centigrade or 35 degrees centigrade from outside can be treated externally to about 29 or 27 degrees centigrade, and then be brought into your operation theater, which doesn't have an impact or load on the air conditioning system within your air conditioned zone. But of course, during the second question, what you asked us, permissions to be given. Now that there have been a lot of, like for example, in fact, we were able to do a lot of services in the hospitals. We were able to give services whenever the situation demanded. All you need to do is just go and meet your municipal officer, maybe your joint commissioner or deputy commissioner of police or anybody, and they will give you a day pass which would say that you are permitted to work. So there are options which are available when it comes to terms of getting permissions or redoing the system. But however, without understanding the design of the required air conditioning system, it is not advisable to do on a trial and error basis, because that would rather complicate your things inside rather than giving a temporary solution, which what you'll be looking at.
For those with split ACs, so what would be the best way out in this scenario that you would suggest now? So just to use another fan filtering unit inside the.
No, it is exactly. Try to look at options where you can have. See, basically, I will tell you something about air changes or ventilation, whatever we are talking about. Ventilation is nothing but air in, air out. So what is and when we are talking of air changes, what is the quantity of air that we are bringing in from outside, and what is it that the air which is inside, which is stale or which may be impure air, is how is it that I am going to remove that air from inside? So these are the two things which we need to look at. So especially if we are talking of a COVID situation here, we would definitely be looking at a place where the patient is infected. We would be looking at a negative pressure scenario, which you are not looking at. No, so you have to distinguish between, first of all, whether you are treating a patient who is infected with COVID, or he is a patient who is not infected, but you're taking precaution, assuming that he would be infected. So the situation here is that you are trying to take some protection. What is the best protection? What you can do is, see, for example, post-COVID, there were a lot of questions which was asked whether we can run an air conditioning system or not. Now that has been clearly said in all statements. In fact, ISHRAE, that is Indian Society of Heating, Refrigerating and Air Conditioning Engineers, the society which we have brought out a guideline for this COVID-19. It was brought out within 1 week of getting into this kind of emergency situation, which I will be sharing the link, which the document can be downloaded as we move on. Now, in that guideline, it has been clearly mentioned that the best way of bringing in your air change is keep your doors and windows open. Of course, yes, with a limitation. Like, for example, you have an operation theater. Now, you undergo a process of something called as fumigation before you do the operation theater. Just before you start the process of this fumigation, keep your doors open. I mean, I know you will not have a window, the possibility of having a window open in an operation theater, because it could be in a confined space. You can at least keep the doors open of the operation theater. Run the air conditioning system on fan mode. Do not reduce the temperature. You can increase the temperature to say 28 degrees or 29 degrees, which would not bring on the cooling of the air conditioner per se, but it would keep the circulation of air in motion within the operation theater, and keep the door open so that there is a lot of air which is moving out from your air conditioned theater, operation theater, and you do this exercise for about 2 to 3 hours, and then you do the process of fumigation and then switch on the air conditioner normally how you would do. So this is the best possible practice or a natural way of bringing in a ventilation within a place which is confined.
No.
Yeah.
I just have a question or a clarification from you. So basically, when we are having positive pressure and wanting to convert it into a negative pressure, the main idea of having an OT where everything is being pushed out rather than getting pushed in. So if you are getting unclean air from outside, we may end up in problems of increased incidence of...
No, it is not unclean air, sir. A fan filter unit would have a 3-level of filtration. We are talking of MERV 13 filters or HEPA filters in your this thing. When we install a fan filter unit, when you are bringing in the air through the fan filter unit, you will obviously have a 10 micron filter, you will have a 5 micron filter, and finally you come into MERV 13 or MERV 14 kind of a situation, and then you bring that air inside.
Yeah, sorry.
And even when you are taking out also, you are going to install a MERV 13 filter in your exhaust system, which you are going to install, and then take the air out so that whatever is your bacteria or virus or whatever is there is trapped within the filter.
So these are all structural changes that would be required, and it may not be easy for all of us to do it. let's move on from there to say, you said keep your doors open. If you don't have a window, obviously you keep your doors and you are letting the air in from outside, even in the split AC conditions, etc. So we fumigate at night, for example, and then you do it, then you get the air in and then again. So basically, what is the great advantage for non-COVID patients? Because obviously we have a drape and we have things, and our cataract surgery would take about 10 minutes. We are doing it under topical anesthesia. There is no intubation, extubation that is happening. There would be a difference between a general anesthesia case and a local case under topical anesthesia. So would a great need be there to do structural changes or to alter everything to get in negative pressure, or we can continue as things are?
I would like to split your question into two parts. The first question, what you said is you fumigate usually in the night. So what I am trying to tell here is, before you fumigate, please follow the procedure what I told. Keep the doors open, have enough circulation of air within that place. That means you are blowing air from your operation theater to outside by using the air conditioning system, whatever you have. And then once you shut the door, then switch off the air conditioner and then fumigate. So when you come in the morning, there is no question of any infection there at all. And then you continue the normal switching on of the air conditioning system and do your procedure, whatever you want to do.
So that means during the surgery, your doors can be kept closed. That is...
Yeah, obviously. I mean, there's no way you can do a surgery with keeping the doors open. I meant even before you fumigate the process.
Yeah, that's fine. That's the end of the day or whatever it is. That's the time then you wish to do it. That's the situation. And that's why in our guidelines, we have written that the AHU can be kept on at that particular time as also the...
Exactly. Yeah. Exactly. If you are having a regular conventional air conditioning system with an AHU, we do not recommend to switch off the AHU of the operation theatre at all. Because you keep the air changes in place throughout the, 24/7.
Okay. Thank you.
Yes, sir. So this question is for Dr. Mahipal, sir. Yesterday, some people were asking whether we should switch off the AHU or not, because now the guidelines slightly is changed, saying that you can continue to run the AHU in between cases. So they were not very clear whether we should use it during the case is one of the questions that came to us.
No, we have written clearly that you can keep your AHU and also split AC on, and I think that's why I just clarified with Mr. Madhukar, and he's of the same opinion. So I think he has adequately clarified that we don't need to switch it off, because the positive pressure that you have is going to give you the 20 air exchanges, etc. that you want. So at least that is working.
Yeah. I think it's the point is well clarified. The next question was with regard to the OPD. So is there need to switch off the split AC in the OPD is another question that many people have asked.
So I think again he has answered, and I'll again ask him. So basically the point is that if you can have a fan or something blowing out, so that again there are more air changes that is there. Otherwise, I don't think you need to keep your AC off in the OPD, Mr. Madhukar.
Definitely, sir. Definitely. See, ultimately, why we are talking about air changes is to drive away whatever your virus or bacteria that could be present. So, the more the ventilation, the better.
So actually, the only problem is that a lot of new buildings are made without ventilators and without things. So that is the problem.
That is where you need a mechanical ventilation system in place.
But you don't need to put off the air conditioner. Actually, there was this one article about the restaurant where the people were sitting in Wuhan below that, and they got infected. So I think that's what's created this.
No. Sir, there is a lot of myth about air conditioning system.
Yeah.
The first thing, I think now from fire we are moving on to infections, because a couple of years back, whenever there's a fire, the news used to be that air conditioner spreads fire. Now it is coming to a situation that now air conditioner is spreading infection. I'm sure that this is definitely not true, because see what does air conditioner do is within a confined space, whatever air is there, we are just trying to recirculate that air within the air that is available. So obviously, if you have an air which is infected, certainly the air conditioner there would recirculate the same air. However, the challenge what we have got is how we remove this infection in case it's an infected zone is by having more number of air changes or bringing in outside air into the place.
So I think we can also ask our Manotosh and Dr. Aravind Reddy if there has been any structural change or any AC change that they have seen within their hospitals, especially the ophthalmic thing.
Luckily for us, we've had a laminar flow theater, so there's been not many issues. Unfortunately, we've not started elective cataract surgery yet. We should be starting soon, but then the plans are that we try to perform surgery on COVID negative patients in a different site, so we don't contaminate the same operating theaters. So I'm working in a multi-specialty hospital, which is, I think, representative of most parts of UK. So the operating theaters, unfortunately, sometimes get used by other specialties too. So I think the guidelines are quite uniform. When there's a COVID suspect patient, all the precautions of PPE come in. When there's COVID negative, then the question of aerosol generating procedure comes in. So if you're doing vitrectomy, aerosol generation becomes an important aspect in there. So there's going to be full protection for that. So the move in the UK is tried to, and in fact, the Royal College guidelines recently published suggest that we tried to perform COVID in patients, surgery on COVID negative patients in a different setting altogether. That's possible if you have the resources. If not, then it becomes tricky. But in India, it's most independent hospitals or units run could afford to not see COVID suspect patients. I think that, does that answer the question or?
Yeah, pretty much. Manotosh?
Okay, so same for me. I mean, I do institutional practice as well. So typically, we have total 40 operation theaters in our hospital in 3 locations. So we normally operate in the day surgery theater. And basically, as he mentioned as well, that we have stopped all these elective surgeries, but we have been doing it a month ago, just stopped last month, not because we cannot do the surgery, because our manpower has been deviated to the more critical areas. That's the reason why we have stopped the surgery. So we don't use any negative pressure OT or anything. We are using our normal positive pressure OT. Only thing we do for the general anesthesia cases is a little bit different practice. Basically, anesthetist, because there is a little bit of chance of aerosol generation and all the stuff. So the anesthetists are on full PPE and they do the intubation, and surgeons doesn't go in. We stay outside. After the intubation is done, maybe around 10 minutes later, we enter, we do the surgery, and before the patient extubated, we just leave the OT. So that is the only practice difference here. I do understand that we have prepared, our center, NUHS, has prepared 2 negative pressure OTs for the contingency. That is in a separate area, in the main OT area. In case we need to operate on some COVID positive patient, we'll be using it. But so far, my knowledge, nobody has used that OT yet.
I think as of now, as far as the research that I've done, there is no report in ophthalmology of any surgeon operating on a COVID positive patient as of now. So that is the state, although we need to be prepared for these kind of cases. Next, another question is regarding the use of UV inside the OT and in the area ending unit. And Mr. Madhukar, what we wanted to know was how we can do this easily. Is it difficult to fix a UV into the AHU if you don't have one with it's got a UV filter in, UV light in that, UV chemistry.
Yeah, let me just answer that question. I would like to show one small slide when it comes to the UVGI and how we can do it. Can you see my screen?
Not yet.
No, not yet.
Not yet. Yeah, one second. Yeah, I think now you can see, right?
Yeah. Yes.
Okay. So let me show you the slide. See, again, what happens in a UVGI is, sorry, I'm going back to this. We come back. Yeah, this is a typical image of a UVGI lamp. So yes, this will certainly help. because if you look at this picture here, now this has got an image before what you had a UVGI filter. This is how our cooling coil inside an air handling unit looks like. Now with the UVGI filter, this is how it looks like. That means there are enough proof that these UVGI lamps do have an effect on these air handling units in terms of keeping this coil clean. Let me just answer this question specifically. This UVGI filters, that is the ultraviolet germicidal eradication filters, will keep the cooling coil clean. However, it doesn't clean the air. Let me just re-stress this point again. This cooling coil, which would have a lot of these molds and fungus and bacteria and etc., which would get attracted by the air circulation, gets cleaned by this UVGI and necessarily not the air. So the one that keeps your air clean is again your process of filtration and not UVGI. So per se, UVGI again helps only in keeping your cooling coil in the evaporator clean, but not the air path. I hope that answers my answers the question.
Yes. Yeah, very, very important point that you made. It doesn't purify the air with respect to the virus, but keeps the cooling coil clean. Is what?
Yes.
Correct statement. Right. That's a very important point that I think
I've shown a picture here also. If you look at this picture here, this is a cooling coil, which is the general condition of a cooling coil. Now this is the
light is going to fall on it continuously to get that germicidal effect.
Exactly, sir. Exactly.
So I think, thank you, Mr. Madhukar. I think you answered most of the questions and cleared our doubts. Thank you very much for joining us, Mr. Madhukar. Mahipal, sir, if you have any other questions.
I would just...
Yes, sir.
No, I would just like to share one document like what I was talking about.
Yeah.
Anybody who would like to know more about, I'll just share my screen for a minute for this slide. Yeah, hope you can, all of you can see this slide here. One second.
Yeah.
This is generally the guideline which I was talking about. You can just, this is for the information of everybody. Now, ISHRAE has released this guideline called COVID guideline with respect to an air conditioning system. So this it's a complete document about how to restart your operation theater. What are the procedures that need to be followed when you're handling an operation theater? When you're handling a common split air conditioning system, what are the precautions you need to take? How to restart this kind of a system? This document has a complete detailing of the entire myth which was there as far as air conditioning was concerned, and it is downloadable. It's free of cost to everybody from www.ishrae.in. You can please download this document, and it is available free of cost for everybody.
Thank you, Mr. Madhukar. And any other questions for Mr. Madhukar? Mahipal, sir, you want to ask him any other questions?
I think he's answered all the questions, whatever were the doubts, and I think our document that we have released from AIOS would not require any changes because I think it follows exactly what he has said.
Yes, sir. I think most of the doubts which was there for the doctors have been cleared, and I think the AIOS guidelines and Mr. Madhukar's seem to go hand in hand, and it's very good for all of us here.
I think it is good to always hear from an expert first hand. So I think he's cleared all our doubts. Thank you, Dr. Madhukar. I think it was great listening to you.
Welcome, sir. Welcome.
Thank you so much, Dr. Madhukar. Yeah. To the last part of our session, here we deal with the PPE. I'll try to tell you very, very briefly about like what are the different kinds of PPE that we have, and some of the remaining questions that have been asked to us, we will deal with within the next 25 minutes or so. So in the PPE, there is a lot of confusion happening. People not knowing what exactly is a PPE. To start with, let me tell that there are 3 levels of PPE available: level 1, 2, and 3. The level 1 PPE what we use is for the most basic uses, like say for example in the screening areas, in the isolation areas. When it concerns to us in ophthalmology, it could be mainly like where we do the triage. So this is where we need the level 1 PPE. The level 2 PPE will be in the treatment areas where we have some patients with fever coming in, or we are treating such patients. That is where the level 2 PPE comes in. The level 3 PPE is usually for people who are actually in the intensive care units or where the COVID patients are admitted actively being treated. So this is where we require the level 3. It is extremely important that we differentiate these 3 levels of PPE, or else we wouldn't know which one to use exactly. So let me start with the level 1 PPE. Level 1 PPE will be something similar to this. This is the operation theatre gown, which we do use normally, the disposable gown what we have with a cup, something similar to this. This may not have a hood like how you see in the level 3 PPE. So this is approximately about 40 GSM, and this is water repellent. This is not just a cloth material. It is called as non-woven fiber with a mix of plastic within it, which is polypropylene. So it is a mixture. It is actually a 3-layered gown with 40 GSM. And if you put water, you will see easily that it doesn't percolate. It just goes away and splashes out. So this is the simplest thing what we can use as the level 1 PPE. The level 2 PPE is of a slightly thicker material, which I'm showing it to you here. So this is made of again a laminated fabric. So it will have 2 main layers. One is a laminate fabric layer in the beneath, and then another lamination on the top. So the fabric and the lamination together, the lamination helps in a very, very good repellent property, and whereas the fabric makes it more breathable. This is typically of something like 60 GSM to 65 GSM, not so thick, but then water repellent enough so that moderate degrees of exposure, like patients who have fever, where we are treating those patients, where they are not COVID positive patients, such situations, the level 2 PPE would be pretty much acceptable. It comes usually with, it can come with a hood, something like this, and a zip, something like that. So you have these things. You usually typically use it with either a 3-ply mask and a goggle, or even an N95 mask. Next comes the level 3 PPE, which is most critical. This will be, this is the level 3 PPE, comes like this. You have the hood, which is similar to this, and then, with a zip in the front. So this is what is called as the seam sealing. Wherever there is a stitching of the PPE which has happened, this is a far thicker material of roughly about 90 GSM to 110 GSM. Again, this is also a non-woven fabric with a laminate on the top. That means the laminate means basically you have the laminate cards which you do to make it hard on the outer surface, the plastic lamination. It is similar to that, where the fabric has a lamination so that it gets its water repellent property. Wherever the stitching is done, all those areas, this stitching, wherever the needle pokes in, it can create holes. So in order to seal these holes, even these become critical so that the viruses don't get inside. So these areas are something called as heat seam sealed. What is meant by heat seam sealed is there is a tape which is put in these areas where the needle pokes in and stitches it, and this is sealed by the heat so that the heat pushes the seams, the sealant inside so that the holes get covered up. This comes complete with foot cover here. So this is called as the level 3 PPE. Level 3 PPE comes along with either a respirator, or you have to use it with N95 mask and then goggle, which is really tight on all the surfaces. So this is really airtight and then doesn't allow any percolation from any corner happening. Now coming to the next few questions that we have. So one of the questions that concerned us was regarding the trial frames. There was a very, very common question which was being asked. Now, which is the this question goes to Mahipal sir. Which is a easy way of doing sterilization of the trial frame and the trial set. So the trial frame, quite a lot of people, what they have been doing is they have attached optical shop, and in the optical shop they have this UV sterilization. So they have been utilizing the UV sterilization coming from the optical shop to do the sterilization. What would the AOS recommendations be as far as sterilizing the both trial set and the trial frame, sir?
Trial frame, there is no problem. You can use 70% isopropyl alcohol. There is absolutely no problem. You can use hypochlorite. You can use hydrogen peroxide. For the lenses, you can use alcohol. It doesn't kind of spoil them. You can do that. And otherwise, you can just do soap and water. You have a bowl and you put soap and water in there. And if you have a UV light, that's fine. But I think alcohol is what we use everywhere, and alcohol would not spoil your trial frame or trial set. The only thing is when you're going to an optical shop, that is the time when you should use tissue papers, dispose it off, and put some alcohol on it, and you can do that. And what you should try to tell the patients is not to try on too many frames because that takes, so they should only try on the only particular frame that they really, really like. So I think there isn't too much that you need to worry about from that perspective. So either of these things can be used. I don't see any, even soap and water, you can just keep it there for 5-10 minutes. If you are put the lenses in there after using, you can do that, and your hands are having gloves. So gloves we are wanting even the optom to be wearing, and they can use alcohol to clean their gloves, etc. That's not a problem in between cases.
Dr. Vinod, I want to ask you this question which we've been getting. Surface cleaning, we've been doing using 1% sodium hypochlorite. What I want to know is whether what is the right concentration of sodium hypochlorite that we need to use, which areas, and I will probably ask the question in 2-3 parts. Whether is sodium hypochlorite safe on all the surfaces? Do you have alternatives? Which are the areas we cannot use sodium hypochlorite? Can you please clarify these to us?
Yes, Dr. Sirish, thank you. So I would say first take the first bit of it, that is sodium hypochlorite itself. Sodium hypochlorite has been proven to be one of the best disinfectant that we have in last couple of decades, and it has been one of the gold standard, I would say, in terms of having the active ingredient chlorine and how it's effectively acting on all the microbial and microcidal activity against even in the soil condition. So now in all the recommendation from the government of India, even the reference from World Health Organization, all from the West, from Central Disease Control, every book, every guidelines, they talk about the sodium hypochlorite solutions ranging from 1% to 10%. Now the question comes, like you rightly mentioned, Dr. Sirish, okay, which concentration is it good for us to use? So I have worked, say, since there's a series of concentration range in healthcare facilities, especially. I would say if the surface and the areas where it is very, very critical. I mean, in terms of the few minutes back, Dr. Mahipal sir was mentioning that the lenses can be cleaned with alcohol. That's one of the examples I would like to take. Like, yes, because you cannot add sodium hypochlorite to that kind of equipment or a surface or certain critical equipments. So when I would suggest that in a triage area or in a patient visiting lounge area, and where there's a lot of foot traffic and you're going to expect a lot of soil coming in along organic matters and everything, there you can use the sodium hypochlorite solution. Proven studies, they are published that using a lot of laboratory viruses to study that 0.1 percentage till 1% sodium hypochlorite is enough to get rid of this enveloped COVID virus. So we are dealing with the enveloped virus. There are two types of viruses we have. So one is enveloped, one is non-enveloped. So enveloped virus is, have a very sensitive to sodium hypochlorite as well as to alcohol. So the concentration is between 0.1 to 1. Now to the specific question, if you want to go towards certain operation theaters or certain sensitive tables, equipments, I would say decrease the concentration and always go with the contact time because the lower the concentration, the contact time will increase. So the higher concentration, contact time will be decreased. Contact time is the time on which the time for which the disinfectant has to come in contact with the surface to achieve the complete decontamination surface. So I would suggest if it is an OT, my first preference would be an alcohol-based cleaning agent. For hypochlorite, I would prefer more into surfaces where it can withstand, like chairs, tables outside, the triage areas and other areas where we can use sodium hypochlorite. And the other reason why I wouldn't prefer sodium hypochlorite to be in a very rooms like where you have operations and everything, surgical suites, as Dr. Madhukar was also mentioning, is a semi-confined area. And hypochlorite, as we all know, is a halogen. It will definitely have a chlorine. And there are certain, evidences have been shown when hypochlorite come in contact with certain materials, and also in surgical suites, there will be a lot of materials that we may be using for surgical, and that might have some byproducts released along with chlorine gas. That would, be a big issue in that area. So I would say anywhere where there's a well ventilated, well open area, sodium hypochlorite between 0.2 to 1% to maximum 5% you can go. And then in the areas where there are delicate critical equipments are placed, I would suggest to go for an alternative, preferably alcohol based. But again, the one challenge there is the contact time for alcohol is also important. It's pretty evaporative, we all know that, but we just want to make sure we quickly get it and do it in one direction. Never a disinfection has to be wiped in a circular manner. It should always go in one direction so that you can repeat it, take your hand and do it again, so that we will have a uniform sterilization achieved. So I hope I covered all your points. If I missed anything, can you repeat any questions if I missed?
There was a question yesterday that I had that was on quaternary ammonia compounds. So I really would wish you to clarify what are they and would they be useful also?
Yes, sir. Quaternary ammonium disinfectants are again a class of disinfectant. Mostly it is based on higher metal salts, and in production areas as well as when we are working in a biopharmaceutical industries or clinical research areas, we prefer for quaternary ammonium salt. And especially quaternary ammonium salts play an important role when we know there are other pathogens involved. So the choice of disinfectant is very critical based on the agent that we are exposed to. So more or less from a biosafety standpoint, I would say that if our present scenario is the coronavirus is the agent that we want to look at, so for that there's a specific disinfectant, and those categories I would say alcohol based, sodium hypochlorite based, and maybe in some level iodine based. Quaternary ammonium, again, quaternary ammonium disinfectant, phenolic based disinfectant are more towards other microbial pathogens, I would say, like TB, where they are very difficult to get in because of the nature of their design, because these are very difficult to penetrate. So these other disinfectants have certain abilities, certain have the clinical actions are they degrade their outer shell, especially for cyst forming bacteria or cyst forming protozoas and those other microbial pathogens. Quaternary ammonium salts, TB, or phenolic disinfectants, those kind of metal disinfectants can be used. So that would be my thoughts.
So in other words, quaternary ammonium compounds are for situations where there is a thick cell wall. We don't need such a strong disinfectant in situations like this. Can we summarize it that way? Is
Yes,
that what?
yes, Dr. Sirish. If there is a condition where you predict that some complexities there, we are dealing with a primary infection as well as a secondary infections which you don't know, unknown together, then that is when we have to, on need basis, do a quick evaluation and go for that kind of disinfectant. But at present, yes, I agree with you. Only when it is chosen based on the agent, and now we can assume that the best disinfectant would be to rely on alcohol-based disinfectant as well as the sodium hypochlorite.
As far as the OT is concerned, I have just a point to make. We all have been using glutaraldehyde or a bacillocid special, which we have already been using it. I think we don't have to change our protocols just for the corona, because the glutaraldehyde base will also be working against them. So the hypochlorite can be kept outside wherever we are using, and whatever the disinfectant that we are using previously, we can continue to use it in our OTs, but make sure that you give the correct contact time. That is the most important message.
Correct. Exactly. Dr. Raju.
The only thing that you could do is that the floors can be cleaned in between every patient with a hypochlorite. That may not be out of place. So you can really do that. That's not going to corrode your, if you don't have a problem using that, I don't think that's a problem, right?
True. That is not a problem, sir. You're absolutely right. In between, we can have certain kind of administrative controls and cleaning and sanitization protocols. So two different things. So I believe that there is also a fumigation protocol that you all follow. So if you have a tier 1, tier 2, tier 3 cleaning process, 3 cycles or everything, if that is defined and there is a good protocol for that, that should pretty much keep us, a good guard on any infections.
Yeah, I have been using sodium hypochlorite to clean our slit lamps after every patient, but then I'm seeing that the color of the slit lamp is actually changing.
Yes, that
is there a more gentler chemical that we can use on some of the metal surfaces?
Metal surfaces, I would still recommend alcohol-based at a different concentration. That would be the ideal one, sir.
Okay.
Now we move on to the next is some of the clinical difficulties when we are using these PPEs and for the patient, and as well as when we are using it. So Dr. Sirish will show some photographs here, and we would require inputs from Dr. Manotosh and Dr. Aravind.
Can you just do the... Yeah. Dr. Manotosh and Dr. Aravind, this is, as you see here, this is a patient where we are taking applanation tonometry for one of our glaucoma patients. Now, if you can see here, what is happening is this patient is putting a mask, and this is a unique problem what we are having. This is a V-shaped mask which is very, very pointed, and you can see how it is butting on the stem of the applanation tonometer here. So this is causing quite a few wrong readings. Now, have you faced such a situation, and how are you dealing with such situations?
Sirish, have you tried turning the face to the side so you can get better access to the cornea?
The mask, actually, these particular masks are very bulky. If you can see here, even to the side of the mask, it is so bulky. The tip is so pointed. I'm asking both of you, since you've been seeing more of COVID patients since much longer than what we've been doing in India. So I was wondering whether you have come across such a situation.
Well, in practice, we just used iCare most of the time, iCare tonometer, which usually doesn't have these problems. In the odd occasion where you suspect that you have to use a Goldman, you can ask the patient to change the mask to something flatter for the moment, like a surgical mask, before and do the pressure check and then disinfect it. The most important thing is to disinfect the Goldman applanation tonometer. Okay, so we tend to use soap-based or detergent-based cleaners. So in the UK at least, I think that's proven to be as good as hypochlorite. Hypochlorite is a little more toxic on surfaces. Does it answer the question?
Dr. Manotosh, anything?
Okay, so we really haven't faced this problem because most of our patients are coming with a surgical mask. And secondly, most of my patients I'm using tonopen rather than Goldman because I normally deal with cornea, so you know the opacity and all. The tonopen is much better. But I do some Goldman, and most of the patients since coming with the surgical mask, I didn't face this problem yet.
Tonopen, you need to go nearer to the patient, right?
Yeah, we need to go to the same for the eye care as well. I mean, you need to go to the care of the patient, but since you have the surgical mask and the patient has the surgical mask, so I think we are quite okay with that.
Okay. Coming to our last couple of final questions here. So we are talking about the waste disposal. Of course, the fact is that we are not facing too many COVID patients right now, but most of them, of course, the guideline says that you consider all patients as COVID positive until proven otherwise, and we need to take similar precautions. Now, as far as the disposal of the OT gowns and gloves and masks, obviously there would be a different care which would be involved from the viewpoint of a COVID patient. And since we don't know the COVID status of these patients, we are unable to test all these patients pre-operatively as well. So do we deal with this waste exactly in the same way that we are going to deal with in COVID patients? Like what I mean to say is when we operate, do we deal with the waste of these patients, regular patients, in the same way as we would thought as a presumptive COVID patient? Or can we take it more lightly? Mahipal sir, and would you want to take this question?
No, I would not personally feel that there should be any, not all patients should be taken as COVID positive. That I think is incorrect. In case you are very, very afraid of it, you could also get a pre-operative COVID test done. The government says it's not mandatory. But apart from that, I think the routine biomedical waste disposal should apply. I don't know whether Vinod has any different views on that.
No, sir. You actually rightly said. We should just consider that as any other biomedical waste rule 2016. We should follow that, and the guideline that under 18, which has already been laid, unless and until we declare that we are the facility is handling a COVID, then the protocol and there's more additional guidelines. Otherwise, more or less, the biomedical waste guidelines for healthcare facilities have been pretty much straightforward because we know that we deal with this on day-to-day basis. So I think taking the existing, the governance that we are following for any, handling any patients at a cardinal rules, we should just follow that and then consider the waste as a potentially infectious material and discard as per the guideline. That shouldn't be any change in that protocol, to my knowledge.
Yeah, thank you. Quick question both to Dr. Aravind and Manotosh. Have you started elective surgeries? Yes or no?
Not yet.
Not yet, because we are not allowed to do it now.
Okay. Sir, a bit of I am trying to play devil's advocate here with Mahipal sir. With all of
having punitive actions against hospitals for not doing their normal work. So, we are caught in it's a question of between the devil and the deep sea. So I don't think we are hurrying, but I'm not very sure as to how long we can continue to lockdown. So I would personally of my 2 cents would be that there could be a change in scenario over the next 4 to 6 weeks, where we might have to alter the things. But as things stand, since the government has given the guideline that we have to, the only thing that they have said is that you should not do anything in containment zones if your hospital or your nursing home is situated in a containment zone. And the second thing is that they have agreed to not start camp surgery for the time being, and mobile services. So those are the things which actually you have congregation of people. So those are the things that I think Bangalore is the place which started first. Shri Ganesh has been doing laser vision correction for more than 2 weeks, and NN has been doing. So I think Bangalore has been much more aggressive in starting.
Ball is in our court.
We have been ahead of the curve as far as starting the cataract surgery are concerned.
So I think Manotosh said that there is no issue in doing a surgery provided they had the manpower and maybe if there wasn't a restriction. I really don't know, because Hong Kong we spoke to Japan, Kyoto, etc., and Korea. They are all doing cases. So Hong Kong actually, I was pleasantly surprised that the return in refractive surgery has been pretty good for the patients, but the older patients are still slightly afraid to come. So the cataracts haven't come back to that extent. So that is what the situation globally is. So ultimately, I think the present decision of the Indian government is to live with COVID.
Okay. So just one last, Dr. Aravind. We have a short time, so let's rush through this. We are just couple of minutes.
Just one quick point. It's important to tell the patients who come in for surgery the risk of them acquiring a COVID infection in the hospital.
So we have a consent. However, form.
Yes, but it's important that they're well informed, and especially elderly people.
Yes.
They understand the consent process and they come forward. In practice, what's happening is patients are actually calling up and saying, "Look, in this situation, I don't want my surgery for another 6 months. Take me off the waiting list."
Yeah.
Okay.
So that's not the case in India, but the point is that there is a consent, and in the consent which AIOS has drafted, there is a special consent for people above 60 and with comorbidities, that you are at a higher risk and that you will be you could have a higher risk of getting COVID, even though we are taking all safety precautions, then you have a higher risk.
Just one last question before we wind up. Probably we can have a very quick answer again from Mahipal sir. This is again playing the devil's advocate here. What I want to know is when we are advocating no PPE for the doctors who are examining.
Sorry?
No PPE. PPE. We are not PPE in the form. I am talking about coveralls. I am not talking about the N95 mask here.
You yourself said there is first, second, third level. So we are saying that we should have the first level along with the N95, along with the face screen. So that's plus disinfection. I think that's what the safety individual, Mr. Vinod, has also said, and that's the Government of India guideline. So actually having the whole cover as was actually agreed by Dr. Reddy, it's going to be next to impossible for you to be your OPDs in. Yeah. And they're not required. See, basically the point is that you are not dealing with COVID positive cases. Yeah, there may be asymptomatic carriers, and then please insist, and I said that's the best investment that you can make. Even if you have to give free masks to any patient who is entering, you don't allow any patient. And the other thing which we have said is that the app, Arogya's app, should be showing green for the patients. So that is mandatory for them to be having downloaded. So I think from my perspective, we have given adequate guidelines. And this I saw also in the SNEC presentation. I also talked to, so we have spoken to almost everybody. So I don't know whether there is a.
I think probably that's the thing being followed all across the world as well. Even I was talking to Aravind just the other day, Dr. Aravind. Even he said they have the N95 mask and then the gowns, and then even they just put a plastic sheet on the surface and that's it. Am I right, Dr. Aravind? He got up to show it.
I'll show you. This is what they're recommending in the outpatient in someone who is COVID negative. Okay, so you wear an apron like this. It's fluid resistant. You tie at the back, and then you wear your mask, N95 mask. So this is enough for a COVID negative outpatient consultation.
Yes, and this reasonably flimsy, and I think it's just plastic, so it won't be difficult to procure them.
And they are single use as well. So every patient will get. Every patient needs one separate.
Okay.
Yeah, I think it's time that we wind up. I thank all the panelists and the experts who joined in with us. The panelists, Professor Mahipal, Dr. Aravind Reddy, Dr. Manotosh, and experts, Dr. Vinod and Mr. Madhukar, all of you for having been here. I thank all the audience for having participated patiently, and CIPLA for having made this possible. Especially Mr. Prashant has gone out of his way to make this happen in a very, very short while and take a lot of trouble for that. I have a special thanks for him. Dr. Raju.
On both of behalf, I would like to thank the whole team here, and especially Mahipal sir for giving us very valuable inputs. And I think the iOS guidelines is the one thing that we all should follow, and I think that will keep us all safe.
Probably there were just 4 take-home points which were important for us, and one important thing which we learned is about the face fitting of the N95 mask, which will keep it in mind, and the rotation of the mask, which was important, and the surface cleaning for the sodium hypochlorite, we learned a lot, and the AC guidelines, which were quite useful. Understanding that the UV filtration is not for the air but for keeping the things clean. These were important take-home messages from this webinar for us today. Thank you all.
Dr. Mahipal, would you like to make any closing remarks, please?
No, I think, thank you very much. I think it's really good that you people are organizing this, as we also learn along the way, and I think it's our duty to have our members safe and to give them guidelines which can be, because there's so much of confusion everywhere, as you have rightly said, and every other person is calling himself an expert. So none of us are experts, but then the collective wisdom of about 200 people was put into that document. And I think a lot of hours went into it, and as I told you, we'll be happy to change the document as and when required. But I think you're doing a great job to let people understand as to the importance of the precautions that need to be taken. And I'm happy to be of any help, any service at any time. But stay safe, stay healthy. That's it, and hopefully we'll all come out of it stronger than before.
Thank you so much.
Thank you very much. Thank you, everybody.
Thank you.